Hello, everybody. I'm Ron Waxman. We are at the COVID-19 series at CRTonline, and with me today, Dr. Pieter Kappetein. He is the Chief Medical Officer, Vice President for Structural Heart, and also Circulatory Support at Medtronic. Welcome, Pieter.
Thank you very much, Ron. Thanks very much.
And you're coming to us from the Netherlands today, I understand.
Yes, exactly. Yes. So I used to travel a lot between Europe and US, back and forth, and other parts of the world as well, Japan and South Africa. Actually, I was supposed to be in South Africa in March, and that meeting was canceled. The meeting in Japan was canceled. That's how it's all started. And then, of course, the travel ban started. So when I was just back home, we were not allowed to get to the US anymore. And so I'm stuck here now, sitting behind a computer and webcams, etc., instead of being there in the US in meetings. So it's different, absolutely.
Yeah, and maybe you can share with us how the pandemic going right now in the Netherlands. I mean, it's been a little bit different than the US in terms of the kinetics.
Yeah, so it started, let's say 2-3 weeks earlier here. And we had the peak about now 2.5 weeks ago. And you see that steadily the cases go down. So actually every day I get a report on my iPhone, and that tells you how many patients are hospitalized with COVID-19, how many patients died due to COVID-19. And so today it was 18 patients hospitalized. And if you compare it to the peak, it was about 400 that were hospitalized in one day. So it has changed dramatically. I mean, and so very positive now. People should still keep distance, and there's a lot of course, signs in stores, etc., to keep distance. But schools are reopening now. It's first children up to 12 years, and then they will also open schools for children up to 18 years. Restaurants can open June 1st, but then only for 30 guests. And you have to make a reservation. You have to answer a couple of questions before you can get into the restaurant. But you see that the situation is changing here. Yeah. So, and it's positive. Intensive care beds are now, at the peak, we had about 1,600 patients at the intensive care in the country. And now there are about 400 patients at the intensive care. And so one of my former colleagues from cardiac surgeons here in Rotterdam, he came here this morning to have a cup of coffee because, the activity is still down a little bit. And in the morning, US is still asleep. So it's a little bit more quiet for me. And he told me that next week they will be almost back to the normal schedule of about 8 open heart operations per day. And still now they're at about 5 or 6. So that shows you that there's a lot of improvement here.
Yeah, so for those viewers who don't know, Pieter Kappetein is a surgeon as well, a cardiac thoracic surgeon. He's been a co-PI on many important studies like Syntax and I think Tavor as well, and others. I'm not going to put all the list, but one thing that I really wanted to discuss with you, because we are struggling with it as well, how do we restart back the operation in the hospital? And maybe you'll give us the European perspective. You a little bit touch into that. But the patient's still afraid to come to the hospital. There's still patients with COVID in the hospital. There's an issue, is there enough PPE? So how is the Dutch authorities or the health system planning to go back to normal operation as the numbers are coming down and down?
Yeah, so in the Netherlands, of course, testing is important. So as soon as people have symptoms of coughing, sneezing, or feel a little bit like fever, then they can get a test now. And the number of tests is now available. In the hospitals, they don't routinely test patients when they come in. So I think what is different, I heard in the US, many patients first get the test 2 days or 5 days before they get into the hospital. Here, this is not routinely done. So only when patients have symptoms, then they are tested.
In our hospital, in our hospital, they're asking now to test every patient that come to elective procedure. Right. And we don't have necessarily enough rapid tests. So you have to wait 3 days, quarantine himself, and after that to come to the procedure. But that's not happening in the Netherlands, right? Is that correct?
No, correct. So, and the other issue is face masks, I think, which is different from the US. So our virologist, the head of virology, say in the country that is steering the committee that looks at the outbreak, he says, actually face masks can have the opposite effect as well, because people may feel, okay, I'm safe now, I have a face mask, and although I'm sneezing and don't feel very well, I can go out because I'm wearing a face mask. And then when people don't know how to take it off, they may touch with their hands a face mask. And then, of course, with their hands, they may touch an object that somebody else may touch a little bit later, and then they may spread the disease. So only when you take public transport, and of course there are people much closer to each other, you have to wear a face mask, but not in stores or if you go out on the street. And so if you ask the question about how do you restart, so it's almost by day that they look how many beds are available, and how many operations can be done. In Tavor, it's a little bit different. They were already back to normal about 2 weeks ago. And mainly they struggle by the fact that referring hospitals did not refer patients because outpatient clinics were closed. So even though they had the capacity to do them, there were no patients to treat. And hopefully that will change now, and patients will get more relaxed to go to the hospital and feel more secure now. And of course, there's a lot of campaign also on television and saying to patients, please, don't stay at home if you have chest pain or if you have, dyspnea. Go to go and see your doctor, because also here patients were afraid to get to the hospital. In other parts of Europe,
with respect to patients, are they really coming, or they're afraid to come to the procedures? Because there's one thing that we open the beds. Are they coming to the hospital?
Exactly. Yeah, they are afraid here as well. So a lot of patients stay at home, and also because patients, when they undergo a major procedure, like a Tavor or an open heart surgery, they want to have family with them. And then if the family cannot visit them, that's of course a reason for them to postpone it, or to say, I don't want to go to the hospital. I'm 80 years old and please let me stay at home now instead of having the risk of getting COVID-19 in the hospital. And
I think the families is very, very important issue, because I think most patients wants to be escorted at least by someone from the family. And so to my view, it's essential that we would allow to get some families to escort them. I mean, maybe the family should be tested to make sure that they are not carrier, but it is very important.
Exactly. I think it's important, especially, when you undergo such a major procedure. And then even if there might be a complication, and the patient has to stay for a longer time there, and somebody has to, help them, or then it's essential that family can come with them. I agree with you. So other countries in Europe run. It's a little bit different. So the Netherlands, we had what they call an intelligent lockdown. So we were still allowed to get to the shops and go out, and still there was a lot of economical activity here. But it's different from, for example, Italy or Spain, where there was a complete lockdown. So there, the start and the restart is a little bit slower than what you see here. So they will take a little bit more time there.
Yeah, personally, from what you have seen, you believe on the stay-home policy, or you think it was a over-restricted stay-home policy? People could have been released a bit earlier, because, in the US, it's still a debate. It runs from state to state, and sometimes from county to county within the state. So what is your opinion as a European resident right now?
Yeah, so even in the small countries in the Netherlands, from the south to the north is only 200 miles. And from the east to west is about 150 miles. There you see a major difference in outbreak. So in the south part, there was a major outbreak. And that's what they attribute to what they call super spreaders. So a couple of people that had the virus went out, and at the time in February there was Carnival here, the Mardi Gras that we have in New Orleans. We have here the Carnival. So people go in pubs, they stand close to each other, they celebrate, and they drink a lot, and there the virus could spread very easily. In the north of the country, actually there was hardly any COVID-19 patients. So of course it's difficult to say, who is now the super spreader and where are they going and can we contain them? So I think testing is therefore essential. As long as you cannot test everybody, I think you have to be restrictive and say, well, maybe you have to stay at home and at least, try to work at home as if you can, instead of going out, and maybe you are one of the super spreaders that can spread the disease. So, yeah.
So one question, I'd like to move a little bit to your role as the Chief Medical Officer. You're running multiple trials in structural, not structural heart disease, and obviously when we started those trials, no one thought about COVID-19.
Yeah. Nope.
Unfortunately, there is mortality, there is morbidity, there is hospitalization. You're collecting all this data. Some of the data, it's hard to collect because patients are not coming to the hospital. So as a company, I mean, how do you deal with it? Because a lot of this is important to meet the endpoints, and they were not accounted before, and there's not even on the case report from. So maybe you can walk me through the steps that you've been taking to mitigate those issues.
Yeah. So first of all, as soon as we heard, the hospitals were overwhelmed with COVID-19 patients, we said, we cannot bother hospitals now at this moment by, oh, please, can you enroll a patient in a trial? So we said we have to stop it because, doctors, physicians have something else to do at this moment and concentrate on something else than our study. The second thing is, of course, you also need to follow up and you need to pre-screen patients. So patients have to come to the hospital. They have to undergo maybe CT scans or echoes, which is also difficult. And the second thing is, of course, patients have to come back to the hospital for follow-up, which is also impossible if there's so much COVID-19 patients and doctors don't have the time to see patients. So therefore we said, let's stop all trials. And so a letter or an email was sent out to all the sites. We stop all trials at this moment. Now we have just sent out an email last week because we heard from a couple of centers that said, well, actually, we are getting back to normal and we can treat patients, we can even enroll patients in randomized studies. So we sent out an email. We respect if you don't have time for it, but once you can enroll a patient, we are happy to help you and please let us know. And so then we can restart the trial. And of course, the other thing what is important also that sometimes you need company employees to get into the hospital to help us a case. For example, with our transcatheter mitral, yeah. You need people to get to the hospital and to help them with the procedure. So therefore, that's important.
Yeah, so that's definitely one of the challenges. Did you change the case report form to capture patients who are receiving COVID or not receiving COVID? And to capture those events, is that something that you have changed in the case report forms and presented it to the ethics committees?
Yeah, so that's by itself is as you know, it's not easy to do. I mean, that's a whole kind of bureaucracy that is going around. So obviously we want to make sure that the patient doesn't have COVID-19 before you treat it because it's a risk factor. And we all know that COVID-19 may also affect, your ventricular function or may affect the heart. So therefore we want to, of course, exclude patients that have COVID-19. I think a TVT registry has updated their case record form to capture it as well. And of course, we want to also know whether the patient has some kind of other disease. So I think there's a field everywhere on the ECRF where you can have an open field where you can write it down. I don't think we have a data field yet for it, but that's something we should include as well there. Yeah.
Yeah, let me ask you as a surgeon, few thoughts about, we just discussed earlier this morning on our CAT conference, a patient presents with 3 vessel disease, a very high syntax score, left main bifurcation, right, you name it. He has some fever. We're not gonna have the COVID-19 data, probably gonna take another day. Usually before it was not even an issue. You send him to surgery, they'll do it right away. So did you hear on surgeries being done, I'm talking about it right now, CABG or valve replacement or emergency surgeries done on patients who are with COVID-19?
Yeah, so there have been some surgeries in patients with COVID-19 and the outcome was not great. I mean, some patients really turned very, very sick. And I also heard a patient died who were operated, who turned out to have COVID-19. So yeah, you want to avoid that, absolutely. Yeah.
Okay, that was our thought as well, that patients who are suspect of having COVID-19 should not undergo surgery.
Yeah.
Now, in your next role or in your current role, you're already in charge of all the circulatory support. So a lot have been discussed. I mean, you have different types of support, and I think again, Medtronic also involved in that. Where do you see the role of those devices, and how do you target them towards patients right now with COVID-19 that are requiring mechanical support?
Yeah, of course, also the activity with left ventricular assist devices with hardware was down the last couple of weeks. And the question is, of course, is it just postponing cases, or is it, or will those patients never show up anymore? So we asked a lot of surgeons also in the US last week, and actually most of them said they have done some LVAD implants because patients really needed it, and there were patients that they could postpone. I think what was great to hear that they stayed in regular contact with them. So they had either the nurse calling them every couple of days or the surgeon called them and said, how are you doing? And as soon as they got a signal that the patient was deteriorating, the patient would come to the hospital and they would get an implant. And remarkably, I also heard that a couple of sites actually said, we have done more transplants than we normally do, which I thought was quite, remarkable. And they said, well, there were some hospitals that closed their transplant program, and so they got more donors offered, and so they could do more. So there might be that some hospitals stopped their transplant program, and other hospitals benefited from it. They could do more.
In our hospital, actually, there was increase in the transplant, and I'm not sure, again, how do they get all the hearts, because, a lot of the hearts coming from accidents and people are not traveling so much. Maybe they're riding faster because roads are free. I mean, it's like, but I still get a mixed information about whether patients who are undergoing transplant, and maybe you know about LVAD as well, during the pandemic, I mean, are the results is good, or they also at risk to have more complications because of, they're immunocompromised, they have to take all those other drugs, and potentially they could be more high risk for infection. So what do you hear about the transplant?
You're absolutely right. That is definitely a concern. And I think the truth, I guess we have to wait a couple of weeks before we see all the numbers and all the how patients have done it through the last couple of weeks and how survival was. What I heard, so let's say more anecdotal, that the patient did well, and so they could keep them in a separate part of the hospital where there was no COVID-19. And I think that's crucial. That you hear more and more hospitals that either are dedicated hospitals for COVID-19, or they keep a certain part of the hospital dedicated for COVID-19. And also here at the Erasmus Medical Center in Rotterdam, so that they now open a separate building. And so because they foresee that the coming year they will have COVID-19 patients, and that they have a separate entrance for patients to go to that part of the hospital. And the other part of the hospital, they want to keep clean from COVID-19.
I mean, I think that's very important. I agree that we need to provide to the patients a COVID-free environment if we want to get them back, and also to protect them. So we cannot build new hospitals like in the old days when my grandfather was there. They had tuberculosis sanatorium, they used to call them, but of course, or even for leprosy. But this has to be just addressed maybe in a separate. We have to put some firewalls between those patients. So
how do you do it in your hospital? How's your hospital?
So right now we are not allowed to do elective patients because the mayor of DC going to make the determination. But we are preparing to discuss this, and I actually was interviewing Nicholas van Dingem, and he told me about the idea of Rotterdam, the Erasmus Center, to separate it. So I said to them, I think this is the brilliant idea that we should adopt also here. And they're going to think about having separate entrances, having areas, for example, cath lab, EP lab. They potentially can be completely free of COVID with a different entrance. So we're considering that. The other issues are some companies in the medical devices were very much affected by the pandemic, and they are really struggling. Medtronic does have ventilators, so at least I know with Covidian and others, but it looks like Medtronic is doing okay for right now. I mean, do you have any insight? What is the future or the near future? I mean, we're talking about what is your CEO's message telling you? When are you going to come back to normal? Is that fourth quarter? Is that the first quarter in 2021? What is that you hear, in the corporate level?
Yeah. So of course, everybody wants to get back to normal as soon as possible. And you see that from all the big companies, of course, that are also in the medical device industry. I think the advantage that Medtronic has, it's such a big company with so many different products that, as you already mentioned, if one part is a little bit down because there's less procedures, the other, because of the ventilators, for example, they are going up. So the production of ventilators was increased a lot. And so to be able to support hospitals that needed ventilators. And so if one part of the company is not doing so well, the other part of the company can support it. So I think that's the advantage that we have. And so,
yeah, so that's the beauty of diversification. You have a lot of products and you can continue to function. Maybe I'll finish with the topic that both of us likes a lot to talk about is Tavor. And we are already deep into the approval of the low-risk Tavor. And there was, again, a lot of pushback back and forth from surgeons. We had some discussion at the CRT meeting about it. After that, they were not like really meeting in person. But what is your feel once we're getting out again of those pandemic? Are we seeing a kind of pushback of the surgeon going back to do more Tavor in the younger patients in age, in patients, or it's still going to be escalation to Tavor will continue to replace Tavor? I'm talking just about the low-risk patients, because these are the area that still, I can give you like 3-4 arguments why people continue, what the surgeon says, why they should continue to do surgery, access to coronaries, Tavor in Tavor, Tavor in Tavor,
bicuspid valves.
I mean, you know all of those, but what is your thought? What is your feeling, and how is Medtronic is, because you have both valves. I mean, you have surgical valves and you have the Tavor program. So how do you see that from a company perspective? Where should we expect that field going with respect to the low risk?
Yeah, no, excellent, of course, point that we are discussing internally as well a lot. And I think if you look at the TVT registry, what is now the mean age, I think, is still around 79 or 80 years of the patients that are treated in the US with Tavor. So and at meetings, we're discussing a lot about the 65, 70-year-old, 75-year-old, but still, I think there's a long way to go before all patients who are, let's say, 70 years of age will get a Tavor. Still, a lot of these patients currently are operated. So I think it's all, of course, comes back to the heart team when they sit together and say, well, what is the risk of this procedure in this particular patient? If it's 70-year-old who has 3-vessel disease, needs coronary bypass surgery at the same time, I think it's obvious that patient will get an operation. But on the other hand, if it's a 70-year-old who is, frail, and we all know that, that biological age is so much more important, who doesn't have a lot of other comorbidities, but still, is frail and maybe, cannot undergo surgery, then of course that patient should get the Tavor at this moment. And I think the beauty of the low-risk trial and the approval is that you can do that. I mean, if you see the patients in front of you and your eyeball test tells you, well, surgery will be difficult and the recovery in this patient, you can now offer Tavor. And we know that it works and the outcome will be as good as surgery.
You talk about the 70, what about the 60 years old? I mean, we do have early 60s or mid 60s, they hear about it, they ask for it. I mean, everybody wants to get the minimal invasive, obviously. No one asks for a full sternotomy. So what do you think? I mean, how can we mitigate those concerns? And do you see that, is there going to be an age cut of patients that would say, oh, this patient should not go to Tavor at all? By age cutoff. I mean, I'm talking not frail patients, these are healthy patients.
Yeah, no, I think an age cutoff is something artificial because, if you say 65 or 70, doesn't mean that 69 should get the surgery. And if you're 70, you wait a couple of weeks until you turn 70, then you can get Tavor. I think that's not, I think how we as physicians work in hospitals. You really have to look at the patient. But of course, your question is spot on. I mean, a 6-year-old, will you offer Tavor to that patient? I think it will still be a long time before we do that routinely. I think it will still be exception of the 6-year-old that get Tavor. And even if they ask you, but doctor, I don't want to undergo surgery, you should have that discussion and tell the pros and cons of Tavor and surgery. And then, yeah, the informed consent is getting more important than those patients. What does a patient want? And sometimes there might be exceptions. You know, you say, well, this patient is a 60-year-old, but the Tavor might be the better solution here.
But the answer may be related to the technology, because if you continue to develop valves for young patients, which means more access to coronaries, maybe on durability, maybe it's not going to be an issue to put, you know, when we have restenosis, we put another stent, another stent, another stent,
yes.
get 3-4 stents in the patient. That's,
yeah.
and then we do brachytherapy. But
Yeah.
the question is, you know, right now it's not a good idea to put 2 Tavor in Tavor, because most likely there is no coronary access anymore, and it's going to be a challenge. So that's, I think some of this can be engineered correctly to move more towards the Tavor, even in the younger patient, assuming they will need a couple of valves in their lifetime.
Absolutely. So a couple of the risks that you mentioned, of course, we are working very hard to try to mitigate those risks. So coronary access, exactly what you said, you know, commissural alignment, durability, of course, is a very essential one. And so far, I think there's no signal that durability is worse than surgical valves, so that, which is good, which is great. But conduction disturbance, you want to keep the pacemaker rate as low as surgery, or even lower, better, that would even be better. So all those things, of course, the engineers are working hard on to try to get those risks down. And so far, I think if you have a patient who's 60 years old, who can undergo surgery, and of course, those patients will all be out of the hospital much faster than an 80-year-old. And you can operate that patient. Maybe surgery to start with is the best solution. And then when the patient is, let's say, 60, 75, and needs another valve, you can do a valve in valve.
Yeah. Maybe my last question will be on the bicuspid. That the ACC Medtronic presented the very robust data on the bicuspid, 150 patients. At CRT, we presented 60 patients. Now we have even 70 patients, which we hope to present at the ESC. But my question, if you combine those together, we have already like 220 with very low mortality rate. We had 0, you had like maybe 1 patient. Disabling stroke, also like very minimal. Why do we need a randomized trials with surgery?
You're right. That's of course the discussion, and I think, you know, it will be hard to enroll, and then secondly, what I fear is that if you would do a randomized study, we would already know what the inclusion and exclusion criteria are. So you would design a study which probably will show non-inferiority. Because you will exclude the very heavily calcified ones, the difficult anatomy for Tavor. And so you will almost be able to predict the outcome. And so therefore, a kind of pragmatic trial, I think, is much more likely. That I like that they're much more. And where, you know, the heart team will decide this patient will get Tavor, this patient will get surgery. And you try to capture as much baseline variables as possible, so that at the end you can describe your group very well. And then maybe with propensity matching, you can try to, you know, see what the outcome is different. But I believe much more in that concept than another randomized study. So, and as you know, the discussion is ongoing, and FDA is interested in it, and surgeons, cardiologists will get together around the table and hopefully come up with a solution for it. The next frontier.
Yeah, I think it's going to be hard to do randomization. Also, you have to strategize by the CVERT classification.
Exactly.
And I mean, we have to find, maybe they will use what we have done in our study, trying to match to the same centers from their historical STS database. We can find exactly this patients. That's what we did in the LRT studies. And we did it also with bicuspid. Unfortunately, when we enrolled, the STS just changed it to include the CVERS classification. It was not there in the past. We couldn't get that. And also not all the information was available. But and then there would be still a question of durability, which we would have to borrow from the tricuspid studies probably. But Pieter, it's great talking to you. As you see, we moved from COVID to real life, back to normal. Hopefully it will be quicker as we believe so. And I hope to be able to see you in person soon in the US, which would be
exactly.
both countries.
That we can get on the planes again. Now, and thank you very much for this You know, I'm very honored to be interviewed by a person who has interviewed so many very important persons in the world. So, no, thanks very much, and it was a great pleasure to see you again, and that you're healthy. Excellent.
Peter, stay
Thanks very
safe,
much,
stay
Ron.
healthy. See you soon. Thank
Hope
you.
to see you soon. Bye bye, Ron. Thanks.
Bye.